Good afternoon, everyone, and welcome to today's webinar on common causes of infection outbreaks and management from a mental health perspective. My name is Georgia, and I'll be chairing today's session. Before we begin, just a few housekeeping notes. If you cannot hear or see the webinar properly, please check that your video and audio settings are enabled. A recording of today's session will be sent shortly after the webinar, along with the CPD certificates. I'm pleased to introduce our speaker, Martyn Case, lead nurse for infection prevention and control at Avon and Wiltshire Mental Health Partnership NHS Trust. Please feel free to add any questions during the session in the chat, and we will aim to address them at the end. I'll now hand over to Martyn.
Thanks, Georgia. So let me share the slides. Hope you can all see that okay. So thanks for inviting me to do this talk. I did do it at the recent conference, but we ran out of time. So it's good to have an opportunity to go through it with more time for completeness and possible questions at the end. I am not the Messiah. I am a very experienced IPC nurse, but as Andy Burnham found out when he entered Parliament the other day, we're not the Messiah. I don't know everything, but I'm very happy to share with you years of experience managing lots of these outbreaks and what I've learned along the way, and hopefully it'll be valuable to you. Some of you will be very familiar with a lot of this. Some of it will be new to others. And I've tried to build in as much as possible mental health sort of considerations and aspects. But fundamentally, I'm sure you appreciate the way these bugs spread and the preventative measures and the PPE, etc. It's going to be common to physical health as well as mental health, but there are some subtle differences and possible modifications. So the most common types of outbreaks are either respiratory viruses, flu, COVID, occasionally RSV, and then, of course, my favorite, norovirus. So those are the ones we're going to look at in more detail, and we can group together respiratory viruses. There's subtle differences, but fundamentally the way they spread, etc., will be the same. So we'll start with them first. And an outbreak, this is the UK HSA, is where you get at least 2 people affected by the same infectious disease linked by time, place, or common exposure. So very straightforward. That's what an outbreak is. Sometimes people talk about a greater expected rate of infection compared to background rate, sometimes referred to as periods of increased incidence. So that might be applicable to rates of C. diff, for example, but it doesn't really apply. We need to take the first definition for these types of incidents. What I would say is not to panic. These types of infections are very common. We're all familiar with them. We know flu still kills about 7,000 people a year. So it's not to be taken lightly. But most people fit and healthy will obviously be ill for a number of days and then they get over it. And COVID is certainly not the beast it was in 2020. So I remember very well that nobody had any immunity and deaths were very common. That isn't the scenario anymore. But of course, we do have vulnerable people in our care, and everything we can do to prevent further spread and cases occurring, of course, that's what we should be doing. Within, reasonable adjustments, whatever is practical and reasonable to do. So we'll go into detail of these types of bugs, what they do, what they don't do, because you do need to know what they're capable of, what their incubation is, etc., in order for you to manage them successfully. Now, obviously, those of you that aren't IPC, you won't be expected to manage it by yourself, but in conjunction with the IPC team. But it's very useful to know the background behind some of this. So what is different in mental health when we're looking at infection control and outbreaks? So generally, service users have fewer comorbidities. I mean, that's not always true. Obviously, we've got later life wards in our trust, for example. So elderly people with diabetes and COPD, etc., which makes them vulnerable. But generally, they're not as physically unwell as you would find in a acute hospital. They certainly have less indwelling devices like IV lines and catheters, etc. So the type of risk is different. Very often they're ambulatory and they walk around the wards, and they're encouraged to do that. Not normally an issue, but obviously that does affect the ease of spread. Sometimes they haven't got the capacity, they're not understanding any precautions, or they may not comply with wearing PPE, for example. So one of the things we try to do is a patient with a respiratory viral infection who won't stay in their room, get them to wear a mask if they come out the room. And so that would mitigate the risk to other people. But again, they may not comply with that as well. So we have to be mindful of this and do the best we can. There are issues around waste, for example. A lot of wards, mental health services have had plastic bags banned or certainly restricted because of the incidents of somebody who passed away by putting a plastic bag on the head. So that may be something we have to consider when we're getting rid of infectious waste. There is some similarities to sort of long-term social care. And so when you're looking at HCID guidelines, high consequence infectious disease, there is an alternative model, not just the acute side of things, which is managing HCID in adult social care. That's on the UK HSA website, and we would kind of align ourselves more with that. So you've got people who stay there for long periods of time, and of course, often they do congregate as a group. They might have group therapy, etc. And again, that is part of their treatment, but it does increase the risk of possible spread. Alcohol hand rub is generally used as a sort of mainstay, or has been for many years. Lots of psychiatric wards, it's not safe to have the alcohol hand rub, and so that isn't something that is available in all areas. And finally, most inpatient areas for mental health would be single rooms. So we're not playing what I call side room wars. So for many years when I was in the acute sector, every day there was a constant battle about who needs a side room more than someone else. So you'd have to assess the risk and put the most infectious or the most serious infection in a side room and may have to isolate somebody with an infection in a bay, etc. We haven't got to play that game. Everyone's got normally a single room with an ensuite facility, so that is to our advantage, of course. So let's just go through prevention and testing. Part of the standard precautions, as you'll find on the National IPC manual, is respiratory etiquette. So this is the classic catch it, bin it, kill it. So put tissues in front of your face when you're coughing or sneezing, put it in the bin and then clean your hands. So that will help prevent respiratory viral infection spreading, but it is a challenge with some of our mental health patients to get them to comply with this, or we may need to help them to do it. But that would be something which would help prevent these types of infections spreading. And of course, for all three of the respiratory viruses, COVID, flu, and RSV, there is vaccinations available for those who are in the right age group in the most eligible categories. So where possible, we should be vaccinating them if they're eligible to, again, help prevent, if not the infection completely, but certainly they'll have a much milder infection if they do get it and they've been vaccinated. What I brought in last year for us was a pathway, which, as you can see on the left here at the top, summarizes the sort of classic symptoms of these three viruses. You can see they're all very similar. Most of them, you've got tiredness and sometimes fever. There's subtle differences. COVID's more associated with a continuous cough as opposed to a dry cough with flu, but on the face of it, they're hard to distinguish these symptoms that present. So what we brought in was this for people to follow. As soon as somebody presents with these symptoms, then that's when you implement your infection control precautions. So we would try and advise somebody to stay in their room. Now, as we've already mentioned, some mental health patients won't comply with this. My experience in Avon and Wiltshire, most of them do. There are some exceptions, particularly people who are very seriously confused or agitated, perhaps with dementia. But most of them do follow these precautions. And as long as you explain the rationale to them, and quite frankly, you know, if you've got flu, you're going to want to rest on your bed and not be wandering around and going to group therapy, are you? So we can keep them in the room as much as possible. If they have to leave the room, as I mentioned, they can wear a mask, preferably to clean their hands before they leave the room, wash their hands. The staff then, if they go in to attend the patient, to wear surgical masks, the face visor, that's to protect your eyes as well as your mask, which is protecting your nose and your mouth, aprons and gloves. And the current sort of spacing recommended is 1 meter of somebody with symptoms like this. And I can see it's under review at the moment with the NHS England reviewing this again, but that's the current sort of recommendation. And the PPE should be disposed of as infectious waste. Now, that's not always something as simple in mental health. What I'm trying to say is we often, because of the plastic bag issue, we often don't have bins in the room with waste, plastic bag waste, and certainly for clinical waste, it wouldn't be routinely in the room. And so you might have to, for example, take a plastic bag, a clinical waste bag, with you when you go in the room, and then when you take off your PPE, you can put it in the bag and then take it with you to dispose of it instead of leaving it in the room. So there's things like that to consider. And what we did as well this autumn, winter, we brought in these combination lateral flow tests, which have been very successful. So they test for flu A, B, COVID, and RSV all in one test, takes about a quarter of an hour to do. And then once we've got a positive, we can then decide where we're going to go from there. Or of course, if it's negative, then that's fine as well. So this kind of simple, direct advice is effective. We had very few cases this winter just gone, even when the acutes were suffering with very high levels of flu. We had very few cases. Whether that by luck or judgment, I don't know, but it did seem to be effective. This is a fascinating study. It's published in Nature. You can see the reference there at the bottom right, which looks at, it reviewed like a meta-analysis, sorry, of all the ways transmission of these viruses can take place. So you've got a combination of different things going on here. Possible aerosol, which is controversial, particularly with these type of viruses we're talking about, which are mainly spread by droplets more than anything else. But you do have contact as well, and indirect contact, things like the fomites, pieces of furniture, whatever, they can all be contaminated. So you have got to do a combination of droplet and contact precautions. In the same article, paper, they looked at all the research studies for various types of infections, and it's very complicated, but you can see here at the top left, this column here is COVID, the next one IV is flu, and then MEV is measles, and then further over we've got VZV, chickenpox, and RSV, of course, in the middle there. And what they summarized was, when it comes to aerosols, as opposed to infectious droplets, which we know they are highly infectious, there are no studies confirming aerosols transmission of these three viruses in volunteer studies. We have got that for measles. You can see we have got that for chickenpox as well, and also, interesting, rhinovirus, which causes common cold. So based on this evidence, that's why at the bottom here, we've only got airborne precautions from this listing of viruses for measles and for chickenpox. COVID, RSV, and flu aren't considered airborne, unlike measles is definitely airborne. So if I went in a room with somebody infected with measles and I am not immunized or I'm not immune, I must almost certainly get it. So aerosols, however, can be created in healthcare. So even though the evidence isn't there to show that you've got a lot of aerosol risk from flu, COVID, RSV, if we do any of these procedures with somebody that has got one of those infections, you can generate aerosols. However, you can probably see if you're looking down this list, these aren't the type of procedures we'd be doing in mental health. The only one I can possibly think of is tracheal intubation in an emergency, so awake. Possibly this has been required very, very rarely, but it is possible in somebody that's having ECT and their airway is compromised and the anaesthetist might need to do emergency intubation. So that is a possible scenario. It's very uncommon, but it is possible. But apart from that, and of course, certainly where in our trust, prior to ECT, they do checks on the patient, make sure they haven't got any type of possible infection, temperature, symptoms of anything respiratory, because this would only generate an aerosol with infectious particles if, of course, the patient had a respiratory infection. So if we can exclude airborne and we can exclude, therefore, aerosols, we're back to my favorite IPC manual for England and, of course, the equivalent in Scotland. What we're dealing with these three respiratory viruses is a combination of contact and droplet precautions. So you can either be exposed directly by the droplets, so if they cough or they give off droplets with the virus in and you're close to them and you haven't got any protection on, so the viruses can get in your eye, get in your nose, your mouth, you can pass it on that way. Hence the recommendation for surgical mask and eye protection as well. We use the visor to go over the mask. Also an apron and gloves as well with droplet precautions. And of course, because they're coughing and they're giving off droplets, they will be contaminating their environment. So even if you're not going to get directly contaminated with the droplets from their mouth, respiratory tract, if you touch something in the room which has been contaminated by the virus, you can pick it up in your hands, and then if you rub your eye or your nose without cleaning your hands, you can get infected that way. So these are the national transmission-based guidelines. What's interesting at the bottom of that chart there, if you download it, we've got this bit at the bottom here, and unfortunately they've grouped together droplet and airborne precautions, and hopefully I've demonstrated that the two are slightly different. So if it's airborne, we'd be using a respirator normally, but if it's droplets, you need a surgical mask. So there's a distinct difference. And this last sentence here, and of course, we're not going to have an anti-room. We're not got isolation facilities in mental health with negative pressure, ventilation, etc. And when it comes to the eye and face protection, what they're suggesting of, so you can take your gown and gloves off, or your apron and gloves off in the room and dispose of them in the room, and it may be you take the plastic bag with you, the clinical waste bag as I've described. But then they're saying that the eye and face protection you leave on until you come out of the room, and then you take it off. Now that makes perfect sense if it's an airborne infection and I've got an FFP3 respirator on, which I have to be fit tested for, I'm sure you know. So if I'm going into a room with someone with infectious TB or measles, it would be complete madness to take that respiratory protection off while I'm in the room. So that's where that's coming from. They're saying keep it on until you're out the room and close the door, etc. But that isn't necessarily true or needed if you're dealing with droplet and contact precautions. You can safely take that off as well as your apron and gloves once you're well away from the patient in the room. So there's a kind of subtle difference there, and perhaps they need to distinguish that. What else might be going on? Well, we should start the increased frequency of cleaning, of frequently touched surfaces in shared areas, so door handles, toilets, etc., etc. What is normally advocated when you need disinfection, particularly for viruses, environmental disinfection, is 1,000 parts per million chlorine-based solution. And I know our Scottish colleagues are not allowed to use anything else. This has been going on for years and years, and of course there are other chemicals which are safer and more environmentally friendly. So as long as you've got a product that your IPC team have approved of, you can use something different instead of the classic 1,000 parts ppm, but you do need to have something which obviously is effective against these viruses, and most chemicals will be, to be honest. They're pretty fragile viruses. They're not resistant to chemicals, which is why you can use alcohol hand rub. Make sure you get as much ventilation in as possible. Once you've got more than 2 or 3 cases, we would normally then advise everybody on that ward or unit with the outbreak of respiratory virus to universally use surgical masks, and ask the service users to do that as well if they're not in their rooms. Remind people about respiratory hygiene and hand hygiene. You may need to consider reducing or postponing communal activities. That's a risk assessment you'd have to make at the time. How many people have you got affected? Are the ones which we know have got infections compliant with the precautions? Are they staying in their room, or are they coming out and possibly putting more people at risk? We have to monitor everybody for symptoms and get them tested if they have symptoms, so we know the extent of the outbreak. And, if it's certainly out of control, if we get a feeling that, we're getting more and more cases, particularly if we've got sort of 2 sides of a ward have gone. So a lot of our wards, like many of you will have got like a female wing and a male wing. And if we've just got a few cases in the female wing, we might want to consider reducing or restricting admissions to that wing, but we wouldn't close the male side. But once we've got cases on both wings, that is showing you that we've got spread throughout the ward, and that might be an indication to consider seriously closing the ward. And when we say closing, you know what I mean. Closing to new admissions. Don't bring anyone else in that might be exposed and catch it as well. And again, considering what is proportionate visiting, restrictions or advice. Certainly, if we've got a couple of cases, we may not be advocating no visitors. Certainly, the visitors that are visiting somebody who's a known case, who've got symptoms, you would need to warn them and advise them to wear a mask and clean their hands. And obviously, somebody at high risk, immunocompromised or otherwise risk of serious infection, maybe better to defer that visit until the patient's not infectious anymore. So these are the type of considerations you would have to take into account. In environmentally significance, these viruses, because they are envelope viruses, they don't survive for very long in the environment, which is great. They can persist on surfaces for about 3 days, but within a couple of days, they really do reduce the numbers very significantly from the studies that have been done. They survive longer at lower temperatures, and they will survive longer on non-porous surfaces, like hard surfaces, compared to porous surfaces like materials like clothing and bedding, etc. And RSV doesn't survive very long at all, compared to the other two, but both of them don't have a sort of protracted survival in the environment. When it comes to an outbreak, we need to consider treatments if they're available, and with flu, if it's non-severe, in other words, they haven't had to be rushed into your local acute hospital, there is oseltamivir available orally, and that should be given as quickly as possible. It's more effective if you can give it within 48 hours. So testing with the lateral flow, which gives you the actual immediate result, is useful in it's very quick. But it depends on where you are and what your local laboratory. If you haven't got lateral flow and you send off a PCR for respiratory panel, they can turn that around as well quite quickly. And there is post-exposure prophylaxis, giving, again, oseltamivir to people that are vulnerable groups. So the people that are eligible for flu vaccine, basically you're over 65s and people with diabetes and other underlying conditions, it may be prudent to consider giving them post-exposure prophylaxis, and that has been shown to reduce severity and the spread. With COVID, most people don't need antiviral treatment, but there are treatments available. Again, if they're seriously ill, they've gone into the acute, they will get their anti-COVID medications. But if there is somebody who is not sick enough to go into the acute and they're not improving, you can refer them to the CMDU in your local area, so that COVID medicines delivery units, and they can provide the treatments if the person is eligible. RSV, there's no antiviral treatment. So you need to know the incubations, because that will give us a clue about when we can call this outbreak over. So common cold, 12 to 3 days. So with the flu, it's 1 to 4 days, an average of 2 days. So in other words, if you've had 4 or 5 cases of flu and after a 4-day period there haven't been any more cases, then that will give you a good indication that you've got things under control. COVID is a different animal. Again, it's normally 3 to 4 days, can be as little as 2. So after 3 to 4 days, again, if you've not got any new cases, that's showing things are looking promising, but it can be as long as 14 days. So you may not be out of the woods. And RSV is 3 to 6 days. So what we do here, this is an example of our chart. So if I'm overseeing an outbreak, I need to know when they developed symptoms and where they were what room they're in, etc., etc., because they're not all going to go down at the same time. And you can see with this outbreak we had last year, one on the first, one on the second, two on the second, and one on the third. So over a few days, we had 4 positive COVID. And so then from that, you can then work out when it will be safe to consider the outbreaks over, and if you've had any restrictions in place, or if you've closed admissions, when you can look at reopening again. So flu, no cases for 4 to 5 days. If you've got somebody with symptoms, they can stay in the room, ideally for 5. You can extend that to 6 or 7 days to be absolutely guaranteed that they're not infectious, but normally after 5 days they're not. And RSV would be the same, and COVID would be the same. So this would all be giving a clue when you're coming to the end of the outbreaks. But again, the caveat with COVID is you do need to keep a close eye for up to 2 weeks, because some people do have a long incubation period. And then as each person becomes non-infectious, so if it's flu, and after 7 days, they are now in the room, we can now terminally clean the room. So it's good to get the technical term right. So what we're doing at the end of an outbreak, or we want to clean a room to make it safe, it's a terminal clean. And so once they've recovered, they're no longer infectious, they can come out of the room. We can change the bedding, give them clean clothing, we can wipe all the surfaces, and we can do each individual room as they recover. So we don't need to do like the whole ward at one time. Sometimes people refer to that as a deep clean. When they got staggered, like I showed you on that outbreak chart, we might have somebody in room 16 who first developed it, and now they're recovered. We can clean their room. And then somebody in room 17 developed it 2 days later, so we'll wait another extra couple of days and then clean their room, if you see what I mean. So one by one, we can make them safe. So that was the respiratory viruses. And then just to move on to norovirus, and I'll do this more quickly because it is shorter and we're going to run out of time. So as you know, it's highly, highly infectious. You can even get transmission. It's usually contaminated food. You have to ingest it. You have to swallow it. It has to get in your stomach by one way or another. So if you've got the virus on your hands, you don't clean your hands, or you eat a sandwich or something, you will get that into your stomach. But there's also evidence of aerosolization when somebody vomits. So when they vomit, they give off millions and millions of virus particles. And so if you're unfortunate enough to be in close proximity or walking past, when that happens, you can get that, inhale it into your mouth, and then the next time you swallow, it goes down into your stomach, and you can get norovirus. Usually after 72 hours without any symptoms. Some people say 48. I would tend to go 72 just to be on the cautious side, but normally they're over it quite quickly and they're non-infectious once they've got symptoms. No symptoms, they will still have it in their system. You could still test positive for it in their stool, but they're not infectious as they would be when they're symptomatic. And one of the good things is you get short-term immunity. So you don't get long-term immunity, but short-term, maybe for a couple of months. But what that means is if you've got lots of people going down with norovirus, once they've had it and they're over it and they're not symptomatic anymore, they're not going to get it again. in the short term, so that they're not going to get it during the same outbreak. This is the classic vomiting Larry. If you've not seen this, you can Google it. So this medical student did some experiments looking at the extent of the viruses and the extent of the contamination, and basically showed that these viruses, when somebody vomits, go like meters and meters. So you may not be able to see it, but the sort of, obviously the bulk of it at your feet or whatever, you can clearly see it, but the contamination goes on much further than that. And you only need 10 virus particles to swallow to give you norovirus DNV. So that's incredibly small number, and that's why it's so infectious, because you only need so few. And you can see one person vomits with norovirus could contain enough virus to infect 150,000 individuals. There's millions and millions of virus particles, so quite interesting. Now, most people get over it. It's very unpleasant. I had it once, couldn't stop vomiting. I had no diarrhea, but most people do get over it. But obviously there are some people who have to be very careful with and make sure that the main danger is dehydration, to keep people hydrated. And the significant difference is norovirus is a non-envelope virus, similar to polio is a non-envelope virus, which means it hasn't got a lipid membrane. So the respiratory viruses we've been talking about have a lipid membrane. So when you're using a chemical on them, or alcohol even, it breaks down that lipid membrane and it kills the virus. If they haven't got a lipid membrane, that doesn't work, which is why alcohol hand rub doesn't work with norovirus or non-envelope viruses. And it makes them much harder to destroy as well. So you do have to be very careful about what chemical you're using. Is it something known to be effective against norovirus? And unlike the respiratory viruses, this can survive, because it's a non-envelope virus, it survives a lot longer than your respiratory viruses in the environment. So at least 2 weeks, even longer, some studies have shown. So the bottom line is, I am always much more enforcing high standards of cleaning when I'm dealing with norovirus. I mean, it's important with respiratory viruses, but with norovirus, because it's so infectious, because it survives in the environment, really, really, we need to be right on the ball with this. And even in things like fabrics and carpets, it can survive a lot longer than the envelope viruses. So incubation, 24 to 48 hours normally, but it can occur quite quickly within 12 hours of exposure. And this is useful in your management, so you know, luckily or not, if you haven't had any more cases after 48 hours, then you're coming out the woods, because it would normally present itself. If someone's going to catch it from someone else, they're going to show signs and symptoms within 48 hours. So again, this knowing what the incubation is really helps you in managing the outbreaks. And these are the symptoms, obviously. Sudden vomiting can be projectile. It tends to be more vomiting in younger people, like I had many years ago when I was younger, and more diarrhea in older people, but it can be a combination of both. Watery diarrhea, sometimes abdominal cramps, nausea, sometimes fever, headaches. And as I said, hydration is important. So make sure you report it to your IPC team. You may be considering, again, is it proportional to look at closure to new admissions? Again, that's not something I can tell you what is the absolute rule. Again, I would use a sort of marker there. Is it under control? Have we got 1 or 2 people who have had DMV? They're now recovering. They're staying in their own room. They're using their own toilet facility, so it kind of should be contained. However, if you've had lots of people and you've had vomiting in communal areas, for example, and you would need a really big disinfection of that whole area, the risk of transmission is much more. So you have to take all these things into account. With the staff, again, we're back to transmission-based precautions. Where possible, if you can designate staff for looking after those patients affected or on the one wing that's affected, if it's not more than one wing, that would always be beneficial, but it's not essential and it's not always possible with your rostering, etc. And of course, you know, if the staff go down with DMV, they need to stay off until at least 48 hours free of symptoms, and then they can come back to work. And because they've got short-term immunity, they're not going to get it again. So you can safely allocate these people, if you've got an ongoing outbreak, to look after the service users that are affected, in the knowledge that they won't contract it a second time because they've already just had it. So we keep the residents in their own room, and they've got their own toilet facilities en suite, hopefully. There's a thing, again, I mentioned earlier, this is a recommendation in one of the guidance I looked at, that you may not have infectious waste bins, or you may need to get in these mental health safety bins where you can lock in the plastic bag so the plastic bag can't be accessed by the service user. But it does complicate things, having this requirement to treat it all as infectious waste. And we know the alcohol hand rub don't work because of the reason I've told you. So it's very much washing with soap and water. And again, if somebody has got DMV and they insist on coming out of the room, if you can get them to wash their hands with soap and water before they leave the room, and hopefully they don't have any vomiting or symptoms while they're out of the room, that again would be a sensible precaution to take. So don't use alcohol hand rub, but we do have now these Hochul-based, hypochlorous acid-based hand rubs, which we are bringing in onto our trust, which are effective against non-envelope viruses. So just a reminder, what we looked at earlier. So for norovirus, it's the contact precautions which are advised. So an apron, you may want to wear gloves, but if you don't, that's okay, as long as you wash your hands thoroughly. What is also recommended on top of apron and perhaps gloves is a mask. So in the HIS guidelines, the Hospital Infection Society guidelines, which are about 3 or 4 years old, that's the most up-to-date and best guidelines if you're looking for it. They recommend to wear a surgical mask if you're in a room with somebody who's got symptoms, particularly vomiting, and certainly if you're taking specimens or you're having to help clean up somebody or clear away any vomiting or diarrhea. So there is a place for masks, according to the experts. As we've mentioned, cleaning is absolutely essential. And again, you need something like 1,000 parts ppm chlorine or something that works against viruses. We have traditionally used Actichlor Plus, but we are looking at now bringing in this peracetic acid one here. You can see it's safer, it's kinder to the environment, and it's actually kills the bugs better. And these spill kits we have got in place for vomit. I mean, they're of limited use, to be honest. If it's just liquid, then the granules in there will absorb it and help you deal with it. I'm not saying don't use them, but if there's lots of, undigested food, whatever, then you'll still need to remove that manually. And I wouldn't just, if you've got somebody in an outbreak and somebody has vomited, particularly in a communal area, then just using the spill kit isn't going to be adequate. We know from vomiting Larry, we need to do a much bigger disinfection of the environment. So I'm coming to an end now. You'll be pleased to know. Testing, basically, the bottom line is the only way recommended now, it used to be different, is to get a fecal specimen. So if you've got one or two people, and as soon as they develop symptoms, you can try and get a fecal specimen. I know that's not always easy, particularly in mental health situation, but you can use fecal specimen contaminated with urine from the toilet, get a swab of it. There are ways to do it. But you do need to send it to a lab. There's no local test, and ask for norovirus testing by PCR. Once you've got a few people, if you've got 5 or 6 people with symptoms and you've got 2 positives, you don't normally need to do any more specimens. That's certainly what it's going to be to confirm your outbreak. There's no need to test everybody that develops symptoms. Make sure you don't have any food and drink uncovered. And again, risk assessing and keeping accurate records is absolutely paramount. So this is the type of form I would be used to using. You've got the night shift, early shift, and if somebody has vomited on the Monday, they can put a V in there. If they've got evening shift with diarrhea, put a D in there, and then document, what type of diarrhea it was or what the Bristol stool chart is showing you. So we really do need to have a very good recording of signs and symptoms as they occur if we're going to make any decision about when the outbreak's coming to a close and when we can say somebody is non-infectious. It's absolutely essential. And basically then you can normally say it's over if you've had no new cases for 72 hours. So you could reopen the ward. So if you had 2 people, you've had an outbreak and most people now have got over it, but you've got 1 or 2 people still with symptoms, still within the 48, 72 hours, as long as they stay in their room and don't risk spreading it again to the ward, you could then relax your precautions and just keep that to the 2 people that still got it. And again, you want this terminal clean, and people call it deep clean. It's a terminal clean. It's something at the end of an infectious period. We want to clean that room to make it safe. So we're going to clean all the surfaces. We're going to change the bedding, put them into clean clothing, just like we would with respiratory viruses. And if they've been in their room and they've been vomiting, then I would extend it to things like curtains. So if they've been vomiting because of the spread with the vomit, then the curtains could be contaminated and the virus can survive. if we're doing a respiratory virus infection, then no, the risk is very, very small. Those viruses don't survive on fabric. So you can see the difference. And the deep cleaning, just to confirm, this was something Gordon Brown brought in back in 2007, and some of us were around then. We had high levels of MRSA, and what we mean by deep clean is taking all your, all the back of the beds off, taking off all your radiator grills, emptying the ward basically, and giving it an absolute massive clean. And some trusts still try and do it, but most of them don't from logistics. But that's what's meant by a deep clean. So what we should be calling is a terminal clean when we're managing these outbreaks. Okay, that's me. 5 minutes to go. Sorry about overrunning slightly, but thank you for listening.
Thank you, Martyn. So we do have time for a few quick questions, if you're ready. So Sarah Mansell has asked, if service users test negative on a lateral flow test, are you also carrying out a PCR test?
Not routinely, no. The tests that we brought in, they have been approved, they've been tested to show that they are accurate. But I think we have got that option in most of our sites, and we have done it on a couple of occasions if we're not believing what the lateral flow is telling us, and we're convinced it probably is flu or COVID or whatever. So we have got that available, but we don't routinely do it as a kind of comparison test. Those lateral flows have been tested to a high standard to make sure they are accurate and sensitive. Yeah, hope that answers the question.
And we also have one from Tony Rogers. It says, patients who won't stay in their room, and we know we can't enforce as this would be deprivation of liberty. If they wander with intention, we allocate one-to-one to monitor and ensure safely.
Yeah.
So how do you do the same?
Yes, absolutely. I don't think we have any choice, do we? Depending on what it is, how it's spread, that member of staff may need to wear the PPE, but it's not an easy thing to do. But absolutely, yeah, that there's no other way of managing it, is there? So yeah, would fully support that. Yeah.
Verity Honyu has asked, how did you validate the lateral flow kits?
So it's all available on their website. So in order for them to put lateral flow tests and other tests on NHS supply chain, they have to have been through this validation process. So we don't validate them. They've been done. And with that particular test that we're using, all the data is there. It has to be approved by the MHRA, who regulate it all. So unless they can show high sensitivity and specificity in their tests, they wouldn't be put on NHS supply chain. So we haven't kind of independently tested them ourselves, but we rely on those tests the company had to get certificated on before they could sell it to the NHS supply chain.
Yeah. And also Verity has asked, as ventilation is a real challenge in mental health settings due to the nature of estates, as well as limitation on opening windows affecting natural ventilation, what do you advise for improving ventilation?
Well, you can't, can you, when you're in that type of situation? Most of our mental health units don't have mechanical ventilation, and it's not something you could justify putting in place either. there are, if you're really concerned if somewhere has got very poor ventilation, you can do CO2 monitoring and things like that. We did do that in one area, but you just need to do all you can. So something like hierarchy of controls is to improve your ventilation as much as possible. But I agree, there are some limitations to that because of the restrictions in place in a lot of mental health areas, which makes it less than ideal when you're trying to deal with these respiratory viruses.
So that's all we have time for today. So we just want to say thank you to everyone who joined today's webinar. A recording of the session will be sent shortly along with your CPD certificates. If you do have any questions, please feel free to email us or give us a call.
Thanks, everybody.